Ladies and gentlemen, all welcome. May I invite the chairman of the organizing committee, Prof Muhammed Manga, to deliver his opening remarks. Please, Mr. Chairman, I am welcome.
Northeastern University, my dear father, Emeritus Professor Idris Muhammad, the inaugural lecturer, Professor Muhammed Manga, principal officers of the university, distinguished guests, special guests, members of the University Senate, my distinguished colleagues, members of the academic community, staff, students, members of the press, ladies and gentlemen, good evening. On behalf of the Gombe State University Ceremonies Committee, I would like to welcome us to this very important academic event, a very historic event, that is the 7th edition of the professorial inauguration lectures of Gombe State University. This evening we have Professor Muhammed Manga from the College of Medical Sciences, specifically from the Department of Medical Microbiology and Immunology. And Professor Manga's inauguration lecture will be the first from the medical college. And so that is a history in itself. So without wasting much of our time, I think I have been very hardship every time we come the purpose of inauguration lectures. Very briefly, inauguration lectures are usually organized for newly appointed or promoted professors in a university, where they come and tell the academic community and members of the general public about what they have been doing up to the point they have reached the pinnacle of their career, that is the professorial cadre. And now they tell the academic community what they have been doing and probably what they plan to do going into the future. Of course, at some point, when they reach around the time they reach the terminal point of their career, that is when we also hear about valedictory lectures. Maybe it's too early for Gombe State University now, but for now, let me invite the Vice Chancellor, Gombe State University, Professor Ali Usman El-Nafati, OFR, to come and give his opening remarks before we commence the actual event that has brought us here this afternoon. Assalamu alaikum.
Thank you very much, sir. Chairman of the organizing committee of this lecture series, Professor Muhammed Manga. Thank you, sir.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Our father and our midst, Professor Muhammad, other invited Vice Chancellors present here, Vice Chancellor of the University of Kashmir, and Vice Chancellor of Northeastern University, Deputy Vice Chancellors, Administration, Academic, Registrar, Bursar, and Bursar Librarian, Deans, Directors, Heads of Departments, Professors, other academic staff here, other members of the university community, invited guests, members of the press, ladies and gentlemen, and of course my dear students. Ladies and gentlemen, good evening. It's my utmost pleasure to welcome you to this 7th Inaugural Lecture on the series of global lectures in this university. As much as possible, try to adhere to the university tradition and see our newly promoted professors want to share their knowledge, experiences to the university and general public at large. And therefore, it's my pleasure today having the first inaugural lecture for the College of Medical Sciences, telling you, affirming that the College of Medical Sciences in this university has come of age to produce the first indigenous professor in the college. And soon I'm sure will follow suit. So therefore, ladies and gentlemen, it's a very important topic, information we're going to share this evening. I urge all of us to pay attention to the lecture, to the lecturer, so that we have a good insight into the knowledge we're going to share with us. I know some of the terminologies and things perhaps are difficult for us to follow, but I'm sure we'll be able to grab the little bit is going to explain to us, irrespective of the medical jargons we're going to be talking about. So not to take so much of our time, ladies and gentlemen, you are welcome to this very important event, and I hope all of you are going to join the end of the day with the knowledge we're going to share. Thank you, and God bless.
Thank you very much. Of the State University, Professor Aliu Usman El-Nafati. Thank you very much, sir. Next is the main event. May I invite the university orator and the lecturer, Professor Muhammed Manga, to come over to the stage so that we'll start the event of the day. Thank you. You are welcome. Where is the university orator? You stand here while the orator does the oration. You give him a chance a little, then later you take the stage. Thank you very much. Now I give the microphone to the university orator to give a citation on Professor Manga. Thank you. Before that, may I please recognize the presence of first Professor Prof Muhammed. You are welcome. He's a father, grandfather, and everything in the medical field. You are welcome, sir. Next, we have Professor Umar Patel from Federal University Kashiri and his team. You are all welcome. We also have Professor Yahya Amuda Yusuf from Northeastern University. You are welcome. We have former CMD, Federal Medical Center Yola, who is also here. We have the father, Professor Manga, he is also here to influence the debate. Prof Muhammed Manga, you are welcome. We have the representative of the Grand Kaidi. Kaidi also is also here with us. And also the representative of Shamakin Gombe is also here to represent us. We have Commissioner Abu Dahir, Dr. Abu Dahir, you are welcome. And also another Commissioner, Dr. Garkwa, you are also welcome. Please, I'm sorry for not calling the right name. Thank you. But then you are all welcome. All others that I may not have mentioned, maybe I'm not seen, you are all welcome to this event. Thank you very much. University Orator, please. Thank you.
The Vice Chancellor, Gombe State University, Professor Aliu Usman El-Nafati, Officer of the Federal Republic, the Chairman and members of the University Governing Council, the Deputy Vice Chancellor Administration, the Deputy Vice Chancellor Academic, the Registrar of the University, Dr. Osman Bafetu, the University Librarian, the Bossa, the Vice Chancellor Federal University of Kashere, Professor Umar Pati, the Vice Chancellor Northeastern University, formerly known as Penn Resource University, Professor Yahya Yusuf, the first Professor Emeritus of Gombe State University, Professor Idris Mohammed, the Chairman University Ceremonies Committee, Professor Guramabu, Provost Deans and Directors, Heads of Academic Department, distinguished professors and other University Senate members, other administrative and technical staff of the university, our dear postgraduate and undergraduate students, ladies and gentlemen, I have the singular honor and privilege on this auspicious occasion to present the citation from Professor Muhammed Manga, MBBS, FMC Part, FWAC. Born on the 29th day of October 1977 at Tudunwada, Gombe, Professor Muhammed Manga attended the Usman Memorial Primary School, Gombe, the Federal Government College, Azare, and obtained the primary and secondary school certificates in 1990 and 1996, respectively. Professor Manga graduated from the University of Maiduguri in 2006 with an MBBS degree and proceeded to the Premier University College Hospital, Ibadan, for postgraduate training in medical microbiology. Due to his hard work and abiding commitment, he became a fellow of the National Postgraduate Medical College of Nigeria and the West African College of Physicians in 2014 and 2015, respectively. Professor Manga was highly rated during his medical postgraduate trainings. He worked as a house officer in the then Federal Medical Center, Gombe, between 2006 and 2007, and proceeded to Baza Jasin Clinic in Mina, Niger State, for the National Youth Service Corps. Immediately after NYSC in 2008, he returned to the Gombe State Ministry of Health and worked as a medical officer in the State Specialist Hospital, Gombe, before being posted to the Cottage Hospital, Tumu, as the first medical officer in charge in 2009. As a prolific researcher and for his love to dispense knowledge, Professor Manga was appointed as senior lecturer with the Gombe State University in the 2015-2016 session, and rose to become a professor with effect from 1st October 2021, after going through the rigors of internal and external assessment. Professor Manga obtained several additional certificates, especially in infection prevention and control, patient safety, clinical epidemiology, and medical virology. He was at the headquarters of the Global Virus Network in the Institute of Human Virology, Baltimore, Maryland, United States of America, for the annual short course for emerging leaders in medical virology in 2017. Professor Manga was awarded the SAGE LLC Attendee Scholarship in 2018 during the IPAC Canada Annual Educational Conference in Bath, Alberta, Canada. In 2021, he was awarded the Glenmore Medical Online Postgraduate Scholarship to study MSc Clinical Education at the University of Edinburgh, United Kingdom. He had attended several other conferences and workshops. Recently, Professor Manga was at the Stepping Hill Hospital, Stockport, United Kingdom, for a 3-month clinical attachment in the Department of Medical Microbiology between December 2023 and February 2024. Professor Manga had participated in over 40 trainings, workshops, and conferences locally and internationally, which has added to his versatility in his chosen field. Professor Manga had been the head Department of Medical Microbiology and Immunology, Gombe State University, and the Federal Teaching Hospital, Gombe, between 2016 and 2023. He was the pioneer dean, Faculty of Clinical Sciences, Gombe State University, between November 2016 and November 2018, and was also the first dean, Faculty of Basic Clinical Sciences, Gombe State University, between November 2018 and September 2019. He became the deputy provost of the college from 2019 to January 2022. Professor Manga was appointed the third provost of the College of Medical Sciences, Gombe State University, from January 2023 to date. He has added more impetus to the college in terms of its growth and development. Professor Manga has served in several committees within and outside the university and the Federal Teaching Hospital, Gombe. He was a resource and lead presenter in several trainings and workshops within and outside Gombe. He participated as part of the Nigeria National Technical Working Group on Sexually Transmitted Infections that recently reviewed the national guidelines on sexually transmitted infection. Professor Manga had the opportunity of working under Emeritus Professor Idris Muhammad as a member of the Gombe State Task Force on COVID-19, where he chaired the laboratory subcommittee that spearheaded the establishment of 3 molecular laboratories in Gombe State. He served as a member and medical officer in charge of the airport clinic at Jeddah, United Kingdom of Saudi Arabia, in the national medical team of the National Hajj Commission of Nigeria in 2012. In Gombe State University, he is currently a member of the Senate Business Committee and the University Ceremonies Committee, among others. Professor Manga is an external examiner in 4 universities and had participated in accreditation visits organized by the Medical and Dental Council of Nigeria, the West African College of Physicians, the National Postgraduate Medical College of Nigeria, and the National Universities Commission. Professor Muhammed Manga is also an examiner in the Faculty of Laboratory Medicine of the West African College of Physicians and the Faculty of Pathology of the National Postgraduate Medical College of Nigeria, among others. His special interest is in multidisciplinary approach to combating the menace of infectious disease through infection prevention control, with special emphasis on viral sexually transmitted infection, particularly human papillomavirus. Other areas include patient safety, antimicrobial stewardship, and One Health. He has successfully conducted and participated in the execution of research projects and has supervised 10 fellowship dissertations in medical microbiology and other disciplines. Professor Manga has written over 50 peer-reviewed publications and presented 29 abstracts at conferences, both locally and internationally. Professor Manga belongs to several professional bodies and associations, which include the Nigerian Medical Association, Medical and Dental Consultant Association of Nigeria, College of Nigerian Pathologists, Nigerian Society for Infection Control, International Papilloma Virus Society, Global Virus Network, Infection Prevention and Control Canada, Infection Control Africa Network, International Federation of Infection Control, among others. Professor Manga was recently appointed one of the country ambassadors of the International Papillomavirus Society in Nigeria and is the president of the Papillomavirus Society of Gombe, Nigeria. Professor Manga is happily married, as you can see, his wife and beautiful children. He enjoys traveling on safe roads, reading and discussions. On this note, on behalf of the Vice Chancellor, I beckon on our inaugural lecturer to come onto the podium and profess to this august gathering. Thank you so very much.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. The Vice Chancellor, Professor Ali Usman El Nafati, OFR, the Deputy Vice Chancellors, Administration and Academics, distinguished members of the University Governing Council here present, the Registrar and other Principal Officers of the Gombe State University, the Pioneer Provost of our dear college, and his successor, the immediate past provost of the College of Medical Sciences, who is with us virtually, the deputy provost, deans and directors in Gombe State University, distinguished scholars, professors, teachers, and mentors here present, and numerous that are equally with us virtually. Specifically, let me recognize our grandfather, Professor Emeritus Idris Mohammed, and also recognize my teacher, the immediate past Chief Medical Director of Modibo Adama University Teaching Hospital, Professor Muhammad Awal Abakar, also recognizing the visiting Vice Chancellors of Federal University Kashiri and the Northeastern University, Gombe. Members of the University Senate, my professional and academic colleagues, and other university staff here present, my parents, specifically recognizing my father, and I have to at this point also say it's part of my privileges that I'm the first one to present while equally having his own biological father in the hall. I thank you all. Invited guests, gentlemen of the press, my dear students, distinguished ladies and gentlemen, good evening. Although this is the 7th in the series of the inaugural lectures we have in Gombe State University, it is the first from the College of Medical Sciences, and of course the first from the Faculty of Basic Clinical Sciences, my own faculty, and the first from the Department of Medical Microbiology and Immunology, my own department. I feel really honored to stand before you to present this inaugural lecture. Good evening. While I received the invitation, notification from the Ceremonies Committee that I will be presenting my inaugural lecture in the month of April, my mind kept hovering on several topics, notable among which I will highlight here. The first, I considered this title, Wandering in the Microbial World for the Health and Safety of Mankind in the Tropics. But for some reasons, I dropped that. And I went to the next, the hidden creatures of God with visible role in health and diseases of man, animals, and their environment. I equally dropped that. I went to the third, the unseen creatures and their obvious havoc to humanity. I also dropped that. The fourth one was almost my topic before I finally modified it to get the present topic, which is a privileged nomadic microbial warrior, battles in health and medical education. I consider this topic largely for several advantages it will give me to present both my personal life and professional endeavors as a clinical microbiologist working in Gombe, Nigeria. Before I go into my lecture proper, I would like to highlight some points, particularly do with my pathway to MBBS and the pathway to becoming a clinical microbiologist. As a young secondary school student, then in Federal Government College, Azare, I've already made up my mind that I want to be a medical practitioner. However, circumstances and events that followed made me to go through, different universities, getting admissions to study different courses before finally getting the admissions to study medicine and surgery at the University of Maiduguri. At this point, I would like to recognize the role played by two people in my journey to medical school. First, the late Sarki Malaman Gombe. Alhaji Muhammad Wabili of blessed memory. After my conclusion that I will go to Bauchi to study architecture, and I went to bid him farewell, he sat me down and asked me a question. That you said you want to be a medical doctor. I said yes. Then he gave me one instruction, that you should go and commence your program in architecture, but you must write JAM again. And when you write JAM, don't choose Zaria this time around, choose Maiduguri. And in his words, he said, Professor Idris is there. That time, Professor Idris Mohammed was the provost of the College of Medical Sciences in University of Maiduguri, Borno State. So I've spent like almost 3 years as a student at the Abubakar Tafawa University, Bauchi. Before I was offered admission as a 200 level student, and I moved back to the University of Maiduguri as a student in 100 level medicine and surgery. I've enjoyed many privileges, and I've enjoyed having leaders and mentors whom have given me the love, the care, and the necessary directions that were timely. I trust, I love them, and I respect them. Now to the University College Hospital Ibadan. What happened? How did I get to medical microbiology? Again, now 3 people become prominent in this journey. First, the present Vice Chancellor of this university, who then was the medical director of Federal Medical Center, Gombe. And I went to meet him after some failed attempts at passing primaries in community medicine to ask, what next? And he told me, we can only give you space here if you are ready to go to the laboratory. And the love and trust I have for him made me to accept that without any second thought. The next person was the then CMAC, Dr. Abubakar Saidu, who is now a former Chief Medical Director, and Professor Hamid Umar Pindiga. Because I was about to move to Maiduguri, I tried to dodge going to University College Hospital Ibadan, where my other colleagues were, because I felt I can get whatever I need from University of Maiduguri Teaching Hospital. But the response was slow and a bit uncertain. And that made Professor Pindiga to give me more like a military command that you are going to Ibadan and you can't go to Maiduguri. In his words, in Hausa, ko sun baka a Maiduguri ba za ka zo ba, Ibadan za ka ji. And he gave me this that redirected me and refocused me back to the University College Hospital, Ibadan. And I appreciate all of them. Now, at the University College Hospital, Ibadan, I was lucky and actually privileged again to meet the then head of department, who has remained with me, has followed up with me, and had continued to monitor my progress, Professor Rashid Ajani Bakari, and I will forever be grateful to him. He accepted me not just as a resident, but as a child, and nurtured me to become a clinical microbiologist and followed me up. He not only did not nurture me, but he linked me up with his own teacher and mentor, who is the first indigenous microbiologist in Nigeria as a medical doctor, Professor Abimbola Oshoba of blessed memory. And he equally linked me up with the newest consultant in the department, who has remained with me, Dr. Adiola Fotade. I'm ever grateful to all of them for all that they have done to me. Now back to my lecture proper. I want to go through some basic definitions and concepts before trying to highlight most of the things I have as a nomadic microbial warrior, highlighting my battles in health and medical education. I'm a laboratory physician, and laboratory physician or pathologist is a specialist medical doctor who is trained to interpret and diagnose the changes caused by diseases in the body's cells and tissues. That is a bigger and broader term that encompasses medical microbiology or microbial pathology, chemical pathology, hematopathology, and anatomic pathology. I belong to the microbial family in this regard. So as a clinical microbiology, I'm concerned with the diagnosis, treatment, management, and prevention / control of infections in patients and in the community. Now, the concept of infection or infectious diseases actually reflects three major parameters or components that must come into play to synergistically result into the disease etiology. And we have the infectious agent itself, the host, and the environment. You can have variations in these instances, but all of them must come together to determine the occurrence or severity of infectious diseases. The word nomadic in my title, in the English sense, is just moving from one place to another. But in my own case, my nomadism is both ancestral and professional. Ancestrally, as a nomadic Fulani man, and professionally, as someone who has moved from one university to the other, and also moved from one specialty to the other, and equally moving from one microbe to the other in search of safety for humans and their environment. Medical education, education that is concerned with medical practice or those that are practicing medicine, I want to dwell more on the areas of clinical virology, infection prevention and control, sexually transmitted infections, antimicrobial resistance, antimicrobial stewardship, and patient safety and One Health in my own journey. But before, I would like to give a brief on the microbial world. The microbes actually were in this planet before plants and animals, over 3 billion years earlier than us. And one will ask whether we actually own our world or they own it for us. Because in the real context, they are more in number. They came earlier and they determine everything we do. Even in our own body, they are more than our own somatic cells. In fact, the microorganisms that are in our body far outnumber the cells that we have. And one can imagine if all the microbes in the human body can go wild and become pathogenic, no human being may survive for a few minutes. Everybody will get annihilated. Now, the discipline of clinical microbiology and the practice of microbial pathology. In our own context, and it, of course, some other parts of the world is relatively strange to many people. And so most are not really aware of the roles, responsibilities of a clinical microbiologist. But it plays a central role in the identification, prevention, and treatment of infectious diseases. The discovery of antibiotics by this person, Alexander Fleming, led the entire world, the scientific world, to consider that clinical microbiology and even infectious diseases may not be as relevant again, and so the discipline and their laboratories should all be closed down. But not long after, the occurrence and the advent of multi-drug resistant organisms proved the whole scientific world wrong, and clinical microbiology and infectious diseases remain relevant for the rest of time. Clinical microbiology as a discipline is a bit difficult to codify because identifying a pathogen will require someone to differentiate between contaminants, pathogens, and normal flora, all of which could at one point be pathogenic, in another case they are not. And so it's difficult to have one single formula. That is why many results from some laboratories that are taken by medical practitioners and used in form of prescription to prescribe are actually wrong and end up not just not treating the infections but equally harming the patient by wiping away a number of his flora. There are variations in our clinical practice as medical microbiologists across the world. The concepts, the principles are the same, but the situations we find ourselves actually differ. And also the availability of resources and equipment equally differs. Those are aspects that determines the extent to which the discipline is going to be practiced. There is increasing automation and availability of expertise across the world now determines these variations. Systems, regulations, and guidelines also differ across different parts of the world. Multidisciplinary approach to patient care and mutual respect. Now, these are issues that in our own context are still very much rudimentary, and especially the out-of-pocket spending, I find that to be something very, very classical in form of a difference between the advanced countries and developing countries. You imagine trying to fight antimicrobial resistance and having a patient in a remote location without even the money to transport himself to the hospital and battling with infection. He has no option in most instances than to rely on the 50 naira ampiclox, 20 naira tetracycline that he will get in his local chemist, and these are all drivers of antimicrobial resistance. This, in a way, equally has created a mindset even among clinicians that in a recent survey we conducted, over 70% of Nigerian prescribers rely on laboratory only in less than 20% of their patients. And so most at times it is empirical antibiotherapy in the hospital and is worst in the community. The problem is many of these issues are not recognized, and they are actually there in the mortuaries and the graveyards. And these are lessons that we all need to have. Mr. Vice Chancellor, sir, at this point, permit me to paint two clinical scenarios from my own experiences as a clinical microbiologist. One is positive, the other one is actually negative. The first, which is the negative, is an elderly man admitted with stroke and had urethral catheter inserted soon after arriving to the ward. Few days later, he was noticed to have developed features of urinary tract infection. He was placed on about 4 different antibiotics, second to fourth generation cephalosporins, for almost 2 weeks without improvement. Request for culture was only made when he became very critical, and culture yielded the growth of Enterococcus species, which was multi-drug resistant and intrinsically resistant to all the other cephalosporins that have earlier been used. When we got the result, we tried to follow up on this patient just to realize that the patient died a day earlier. And this is not the only case. This is just one example of what happens with respect to antimicrobial resistance. The second one, which is a very nice story of a young adult who was diagnosed to have necrotizing fasciitis, and whose managing team involved all relevant specialists from the beginning. Although already on antibiotics, but the biopsy taken from the wound yielded the growth of Candida parapsilosis. Candida is not a bacterium, it is a fungus. And no antibiotic will act against Candida. So all the antibiotics that have been used would not work for this patient, and he was placed on the relevant antifungal agent with some other interventions. He got better and was discharged without any major sequelae. Now, coming back to the battles, the first battle upon my return is the issue of sexually transmitted infections, genital tract infections. This is an area that traditionally is being handled by clinical microbiologists, both in Nigeria and some other parts of the world. And so my role as a pioneer clinical microbiologist in a hospital is to ensure that I do not fail my forefathers, and I try by all means to make sure that the flag is continuously flying. And so I got the support of the then hospital management in Federal Teaching Hospital Gombe, specifically the then Chief Medical Director, Dr. Abubakar Saidu, and his CMA, Dr. Zainab Yunusa Kaltungo. They supported the establishment of our own special treatment clinic for the treatment of sexually transmitted infections. But historically, the first sexually transmitted infection clinic in Nigeria was at the University College Hospital, Ibadan, which actually started in the late 60s from a single room, translating into a clinic with both male and female sites that was launched in March 1977, the year of my birth. And this picture you are seeing is courtesy of the late professor, the first professor of medical microbiology in Nigeria, Professor Abimbola Oluoshoba. And now the problem with sexually transmitted infections, especially in our own community and even in the medical context, is such that these are infections that are usually caused by atypical microorganisms in most instances, and many of them fastidious and difficult to identify or culture. Unfortunately, the proliferation and also the infiltration of unorthodox practitioners that paint a lot of false claims in our society is something we need to all work on. If you go from one part of Gombe or from one part, particularly in northern Nigeria, you realize everything is about Ciwon Sanyi, and the other ones, you realize Karfin Maza or other things, most of which are to do with sexually transmitted infections. The experiences we have in our own clinic after the establishment was that the most common presentation was actually vaginal discharge, and that clinic was established in such a way that it can provide both primary, secondary, and tertiary care, and majority of them women that presented with vaginal discharge. And the availability of laboratory that is attached to the clinic, in addition to records, gave everything to be available under a single roof, and that was something that allowed us the chance to obliterate the kind of delays and also the uncertainties of diagnosing sexually transmitted infections. Some of the diagnoses over the years, vulvovaginal and perineal candidiasis is the most common. Others are bacterial vaginosis, genital ulcer disease, non-gonococcal urethritis, genital warts, gonococcal urethritis, and cervicitis. Many women in our locality actually engage in many intravaginal practices, and these are the reasons why they come down with those issues of vaginal discharge in most instances in the context of bacterial vaginosis. Many women use antiseptic soaps in bathing, and some even use it to wash the genitalia. We have feminine wash, and we have many women involved in douching. These days, you have many application of intravaginal perfumes for many reasons. Many other concoctions are being used, some of which in the long run might even have some more disastrous effects. And these are reasons that cause the imbalance in the flora in the female genital tract that eventually leads to bacterial vaginosis, which in itself is a recipe, is a prelude to many other sexually transmitted infections. This situation is actually worsened by the fact that many healthcare workers, uninformed in code or weakly informed, prescribe broad-spectrum antibiotics to women with bacterial vaginosis, and this worsens the situation. And a woman with such kind of infection eventually gets other STIs that leads to tubal blockage, and that's why we have many women still having infertility in this regard. The primary cause is this bacterial vaginosis that we have painted. These are some of the examples of cases that we have seen, just for us to understand the fact that the STI clinic or the special treatment clinic requires some kind of privacy and convenience if you have to manage patients like that. Because part of the problem we have is such that women and men with genital tract and sexually transmitted infections are not as comfortable presenting openly in the hospital, and they find, a solution by going to the traditional settings where they eventually get treated happily. So the first picture there is genital warts. This is caused by low-risk human papillomavirus, and then urethral discharge, which is in this context a gonococcal urethritis that is caused by Neisseria gonorrhoeae, and we have genital herpes, herpes genitalis caused by herpes simplex virus. The lower pictures this lower picture is actually scabies, which in Hausa we call kazwa, even though it's linked to poor hygiene and other risk factors, but it's also a sexually transmitted infection, particularly when you have when there is immunosuppression. Now, the next battle I would like to discuss here is the human papilloma virus, which is an area that is so dear to me, and I've made up my mind as a resident to continue pursuing human papilloma virus for the rest of my life. I first came across this, a combination of emotions, determinations actually pushed me to develop interest in human papilloma virus. I lost a very close relative to cervical cancer in her 50s, somebody very dear, somebody in our own setting, a female engineer, dying helplessly from cervical cancer, which is caused by a virus that has vaccine, a virus that gives window of 20 to 30 years from infection to the development of cancer and gives the chance for screening and treatment. It is something that the whole world has earmarked for elimination by the year 2030, and we still have it as a major problem in our society. And these are some of the reasons why I felt, as an aspiring clinical virologist then, let me identify something that is both preventable and curable, and spend all the efforts in seeing to the fact that something is done to help particularly women before they develop cervical cancer. So the support and encouragement I got from my supervisors, Dr. Adeola Fotade and Professor Bakari, actually gave the initial push. And at this point, I want to report our initial observations in Gombe here. Almost 50% of the women we studied among those that presented for cervical cancer screening in Federal Teaching Hospital Gombe actually carrying the virus. Many of them are in their late 30s, early 40s, and that means the chances are that if they are not screened, they have that chance of progressing to the development of cervical cancer. The use of human papilloma virus DNA testing in the screening for cervical cancer is something that is now global, even though not as universal and not readily available in our own setting, but it's something that is cumulatively cheaper and more friendly, because HPV DNA testing can be done for women using self-sampling. And so you can give a swab to a woman and she can take the sample by herself, as against the other approach which requires her to expose herself for a physician to collect the specimen. And we feel this is something that should be encouraged. And not only that, of recent, the HPV DNA testing will allow someone to have a time lag of 5 to 10 years, if not HIV positive. So the interval is actually longer. And equally, now the world has moved to such an extent that there is DNA methylation. So we can now predict among those ones that are HPV positive, those ones that are likely to progress to cervical cancer. And the management and triaging is entirely different in such situations. So this is something that we need to really support. Nigeria as a country introduced HPV vaccine for the first time as part of our national immunization schedule in October 2023. That's last year. And Gombe State is billed to be part of the second phase, sometimes within the year. And this is something that for us in the HPV, those ones that are enthusiasts in trying to control HPV, is a dream comes true. Because years ago, we had several studies that indicated that even though over 90% of women agrees that they are ready to accept the vaccine in our own setting, more than 90% of them can still not afford the vaccine. now the vaccine is going to be available free, even though paid by someone, but it's very, very important that we support and encourage our young adolescent ladies, girls, to have themselves vaccinated and immunized against human papillomavirus, and that is cost effective. The cost of managing one woman with advanced cervical cancer, even a single investigation, CT scan or MRI, is more than 50,000 naira. And so you cannot compare that to just giving a shot of vaccine that will prevent women, and not only from cervical cancer, but many other malignancies that are HPV related. It requires a multidisciplinary approach, and at this point, I want to encourage particularly community leaders, religious leaders, to take a central role in assisting the medical community to ensure that HPV becomes a thing of the past. Part of my interest in HPV actually made me to join the International Papillomavirus Society more than a decade ago. And that actually opened my eyes. I attended my first attendance at the International Papillomavirus Conference in 2017 in Cape Town, South Africa, was when the International Papillomavirus Society, in that meeting, concluded that each year, 4th of March, is going to be earmarked as a day, International HPV Awareness Day, which we have been celebrating in Gombe here since 2018 till even this year. And we hope this has rekindled and improved the level of awareness on HPV in our society. I had the privilege of not only joining International Papillomavirus Society, but being selected as part of the pioneer set for the mentorship program of IPVS. And I was paired with a mentor who has actually changed my direction of thinking and supported me, encouraged me, and we've established our own local society, the Papillomavirus Society of Gombe, Nigeria. And through that, we have continued to pass the message of improving and making sure that HPV-related diseases are brought to the lowest level we can. I was made one of the country ambassadors by the Papillomavirus Society in 2023, and I'm currently part of the membership committee of the IPVS. This is my mentor, Mark Steven, and this picture is that of the country ambassadors last year in Washington, D.C., when we are inaugurated. Now, aside HPV, I've actually zeroed my mind in the beginning that I am committed to virology. And that made me to join the Global Virus Network, also worked on other viruses, including HTLV. And in 2018, I had the privilege of being selected as part of the emerging leaders in medical virology, and I was at the Institute of Human Virology, Baltimore, for the annual short course in medical virology. That gave me the chance to come in contact with global leaders in virology. And that gave me the chance to develop more insights and have more ideas on how to push and build myself in medical virology. I've had chance to meet those leaders. This picture is that of myself with Professor Robert Gallo. Robert Gallo is the co-discoverer of HIV, and is a foremost virologist who is now about 87 years. And one thing I learned is that commitment and passion to mentor younger ones. In this course, you will never come earlier than him. He will always be there before all of us, and he ensures that he moves not only to give you lectures and insights, but ask you personally what you plan to do and advise. So I learned a lot from that. Now the next battle that I will highlight is that of infection prevention and control. And I will use this slide as an entry into IPC with Florence Nightingale, the nurse that is most popular in the context of IPC, whose words and quotations still resonates in the medical arena as someone who has given direction on IPC. The other picture is that of Ignace Semmelweis, who was the champion of hand hygiene. And what struck my mind was this issue of do no harm. And this is the quotation from Nightingale, the very first requirement in a hospital, that it should do the sick no harm. And many patients still go to the hospital and get infected with a microorganism they never carried from their homes. And this is something that, you know, is very, very important. For me, it's more like being trapped into IPC, antimicrobial resistance, patient safety, and One Health on moral, ethical, and scientific grounds. Because in my own context, it is difficult to practice as a clinical microbiologist without IPC, without antimicrobial resistance, antimicrobial stewardship. And at that time, the hospital itself was trying to strengthen and build the capacity or improve the infection prevention and control activities. And that led to the project on patient safety, which was to strengthen the systems necessary for improving patient safety and quality of healthcare in northern Nigeria, which took place in both Aminu Kano Teaching Hospital and Federal Teaching Hospital, Gombe. It was a joint project with the University of Sheffield and funded by the Tropical Health and Education Trust then. So sepsis as a whole has remained a #1 killer in our own context. If you go to our records, the mortality in our mortuary, you realize that most patients have sepsis as the final pathway, even if they come with a different disease. Somebody that is diabetic with diabetic foot will eventually die of sepsis, not the actual diabetes itself. Somebody with RTA going to the intensive care will eventually die from sepsis, not actually the other things that took him to ICU. And this is something that we must all come together and ensure that we work such that we improve the care of our patients in this regard. Patient safety is beyond infection prevention and control alone. It is a bigger umbrella that talks about all forms of harms in the hospital, including falls, including injuries. And this is something that for the first time in our hospital, as part of that project, we studied the culture, the patient safety culture in our hospital. And the area of strength that we noticed in the hospital is teamwork within units, while the weakest one is non-punitive response to errors. Because most people, even though they have errors, they have committed errors, they have seen errors, they find it difficult to report for fear of being victimized. And that culture of blame is what the whole project tried to discourage. We should shift away from that culture of blame and build a system, and also emphasize on system thinking, rather than trying to victimize or blame anybody for trying to identify himself when he has committed an error. Now, the presence of the infection prevention and control team in our hospital gave us the chance to commence surveillance of healthcare associated infections. But we had many challenges, because the surveillance we started with is laboratory driven. And unfortunately, in our setting, most clinicians don't request for culture. They manage patients empirically. And so you have barely less than 10% of patients that have cultures, and those are the basis, those form the basis on which we have our figures. So you can see that even though we have 4.9, 3.9, this is a 5-year review of our work from 2019 to 2023. But when we try to have it as based on clinical definition, we had almost 21.4%. And that means 1 out of every 5 patients in this context going to the hospital is likely to have a healthcare associated infection. This is really high, and we need to work extra hard. Even though we have paid a lot of advocacies, we have actually enjoyed the support of the hospital management virtually on everything we want to do in infection prevention and control. And I want to, at this point, appreciate the Federal Teaching Hospital Gombe management for giving us this chance. we have made a lot of efforts, and those were recognized by the Nigeria Center for Disease Control and gave us the chance to participate in many projects that are national, many of them that are regional. For Northeast, will have Gombe as the center for the efforts we have made, and some of these things, were part of what we have been trying to present to the global arena, that even gave us the chance to visit and also be recognized in some other fora. Like this picture you are seeing is the picture of the IPAC Canada in 2018, where I was awarded the SAGE International Attendee Scholarship. So, on the issue of infection prevention and control, I will leave us with this quotation from the ancient physician William Osler: soap and water and common sense are the best disinfectants. Antimicrobial resistance. This is one of the greatest threats now to patient safety in the world. It's one of the greatest threats. And while the microorganisms themselves mutate and gain resistance to antibiotics or antimicrobials, we equally have our activities both in human and animal health contributing to that. And at this point, I would like to say that majority of the microorganisms we have now causing infections in our setting, if you give antibiotic without culture, it is just 50-50. It is 50% chances that it may work and another 50% chance that it may not work. And look at the common microorganisms that we have in our setting and the studies we have done here in Gombe. First, the Staphylococcus aureus, which even the other people on the streets actually call and incriminate it even in places where it is not actually the culprit. Staphylococcus aureus in our own setting, the multi-drug resistant type, is almost 70%, 68.5% of the isolates will be resistant to common beta-lactams, common antibiotics that we use. And Klebsiella pneumoniae, Escherichia coli, Pseudomonas aeruginosa, Acinetobacter baumannii, these are all microorganisms that, if we look at these figures, we realize that some of them we can only work in less than 50%. And so it's something that is really scary. And like I said, unfortunately, many of the lessons, many of the messages are there in the graveyards and mortuaries. And most people don't really understand that their role in misuse and abuse of antibiotics contributed to the death of patients in the hospital and even in the community. And this is something that we can see from this trend, that those ones that are resistant, are barely 50%, and we can see the trend with respect to Escherichia coli between 2019 and 2022, still showing that the resistance is increasing. But when we notice that, what we realize, as a consultant in the Department of Clinical Microbiology, I see patients from general outpatient department with multi-drug resistant organisms. And the question is, where are they getting these ones from? It's either they are coming with them from the community, or they have been discharged from the hospital, or both. And trying to follow up will show you that the drivers are actually mainly also in our own communities. And that led us to this study to look at the primary healthcare workers and look at their habits, the prescribing habits, what they do. And we realized that over 90%, almost 96% of them prescribe antibiotics for unconfirmed typhoid fever. Just typhoid malaria, which is a popular diagnosis by anybody, they use antibiotics. And non-specific vaginal discharge, over 95%. Fresh trauma wounds, somebody coming with accident without any evidence of infection, over 90% will give antibiotics. And non-specific diarrhea, just diarrhea without any cause, over almost 90% will give antibiotics. And even for common cold, which is mainly viral, many of them will give antibiotics. And what are their reasons? Some will say they are not aware. And so we need to create that awareness. Almost 87% believe lack of awareness is the reason. And some, about 80%, 79% believe it is lack of penalty, because you just do it and there is no consequence. Nothing will happen. They desire to help patients. Some believe they want to help those patients, and that's why they just give them antibiotics. Others will succumb to the pressure from sales reps, and some others pressure from patients themselves. They want you to give them antibiotics because they believe that this is something that will help them in getting better. And even though they are not workers in the animal industry, healthcare workers in the primary healthcare setting equally give antibiotics to healthy birds and animals. Healthy birds and animals without any result or even a proper clinical diagnosis. So this is to highlight the fact that antimicrobial resistance requires concerted multidisciplinary approach. You cannot solve poverty in the hospital, and you cannot actually be the one to fight ignorance and illiteracy. It's all encompassing, and that is part of the reason why the whole concept of One Health is developed. And you cannot just fight it in the human health without involving the animal health sector and the environment, because in each case, the microorganisms do not have any boundary. They move. They move from the environment to the human population. They move from animal population to human population, and they can cause havoc anytime. Unfortunately, they are equally invisible, and you cannot see them. You don't know what they are doing, and you only see the result, like I said, mostly in the mortuary. So now the final battle, which is the aspect to do with medical education. This is a challenging area for me specifically. As a newly employed lecturer with the Gombe State University, saddled with many challenging responsibilities, I developed a lot of insights, competence, and confidence based on the guidance of our elders. At this point, I will still have to recognize and appreciate our pioneer provost, Professor Garba Ifakalai, his deputy then, who is the present Vice Chancellor, Professor Nafati, and my immediate boss, Professor Babaganaba. We worked together, and they gave every opportunity for me to learn some aspects of medical education. But medical education is a discipline in itself, even though very much rudimentary in our own context, and requires a lot of efforts now to build, and is a very important necessity for good clinical practice and patient care. So, as a pioneer head of department, pioneer dean of 2 faculties, deputy provost of a newly or relatively young medical school, the challenges were many, and those actually made me to develop interest in medical education, that I applied and got admitted to study MSc Clinical Education at the University of Edinburgh through the Glenmore Scholarship. The medical profession as a whole, the medical education needs some level of collaboration with other disciplines if we have to break the barriers. And not only that, we need internal collaborations across most of the other faculties that we have. It is supposed to be multidisciplinary, and we need to use that to confront the modern day, even microorganisms in this regard. The discipline, medicine, and the medical education in this regard also highlights the fact that the regulations is by multiple government agencies in the country. So from National Universities Commission to the Medical and Dental Council to the postgraduate medical colleges, each one having some form of, guidelines and peculiarities. So these are all areas that I think we need to pay extra attention to. Now I want to highlight one point, the aspect to do with the postgraduate medical education, particularly in the training of medical microbiology. And this is something that is purely based on the residency training program, but the recent clamor for the additional degrees in MSc and PhDs, actually is a bit controversial up to this moment, but we have gone ahead and we have established the MSc and PhD programs in clinical microbiology and infectious diseases in Gombe State University, one of the first few in the country as a whole. So to summarize my presentations or the lecture generally, the title again, A Privileged Nomadic Microbial Warrior, Battles in Health and Medical Education. I've enjoyed many privileges, as I have highlighted, and I have actually gained from all the privileges and have utilized most of them. But ancestrally, I'm a nomadic Fulanima, even though for now it is difficult to see that in me, but ancestrally I'm nomadic. And that nomadism extended to my movement from one university to the other before finally coming to medicine. Again, the nomadism continued when I graduated from medicine before coming finally to settle in medical microbiology. And even in medical microbiology, the nomadism actually continued because I actually moved from one microorganism to the other, and I still feel the journey is not yet over. Mr. Vice Chancellor, sir, at this point, permit me to read the recommendations and acknowledgements to conclude my lecture. Now, for the recommendations, multidisciplinary approach and interprofessional collaborations from diverse areas of expertise is the hallmark of modern microbiology and should be encouraged. Connections between experts in the environmental microbiology, infectious disease specialists, engineers, and applied physicists would be of immense help. Patient care in hospitals should optimally utilize available microbiological services and minimize over-reliance on empirical use of antibiotics to ensure patient safety. Clinicians should trust and challenge and encourage the laboratories and microbial pathologists in low-resource settings to become more relevant in patient care and other clinical activities. I equally implore my other colleagues to reciprocate this gesture. Improved nucleation points among institutions, either locally or internationally, will provide common ground for professionals to relate with each other and ensure services, training, and research from diverse backgrounds. Exchange visits, both within and outside Nigeria, will enhance learning and knowledge transfer. Collaborations between hospitals, universities, and industries will provide avenue for mutual benefits. The structure of our undergraduate medical curricula should uniformly integrate basic clinical and clinical sciences such that the graduate medical doctors will fully appreciate the synergy between all clinical faculties in providing them with the requisite skills for subsequent multidisciplinary patient care. Training more medical microbiologists is paramount, and at least all tertiary hospitals in Nigeria should have the presence of pathologists for services, training, and research. The postgraduate colleges should synergize with relevant bodies such as the Committee of CMDs to ensure the improved presence and impact of pathological sciences in clinical and other areas. The postgraduate medical colleges should explore and develop more collaborative relationships with not only the hospitals, but the linked universities for synergistic training and research efforts and outcomes. In Gombe State, the State Specialist Hospital should, as a matter of urgency, strengthen the collaboration with the teaching hospital to harness and build more training opportunities for younger upcoming doctors in the state, particularly in laboratory medicine and pathology. Health insurance scheme that recognizes the ideal way of managing infections and the importance of culture and other investigations should be made universally available. Nigeria as a country should have regional STI clinics with state-of-the-art diagnostic capacities for optimal patient care and research outputs. All tertiary hospitals in the country should prioritize and ensure comfort and convenience of STI patients in obtaining specialist expert care whenever needed. The menace of quackery and the unfounded claims on STIs should be checked by relevant agencies to minimize related sequelae and complications, including female infertility. Now to acknowledgements. First, my sincere and everlasting thanks goes to Almighty Allah, my Creator and my Sustainer, for making me see this day. Alhamdulillahi alladhi bi ni'matihi tatimmu salihat. I thank my parents, particularly my father who is seated here, for rightly bringing me to this planet and nurturing me through the entire journey of life whilst still supporting and encouraging me up till this moment. My family is my strength. My wife and children contributed in no small measure to all my successes. My wife has remained a solid rock and a reliable partner who believed in my cause and whose everything is for me and our children. May we be together in Jannatul Firdaus. I cannot thank my teachers and guardians enough. I wish to pay special tribute and offer my fervent and hearty prayers to late Sarki Malaman Gombe, Alhaji Muhammad Wabili, for refocusing and supporting my dream of becoming a medical doctor. Professor Emeritus Idris Mohammed got me admitted to study medicine and has remained very key in my life all through. He challenges and guides even when it is difficult to match his expectations. May Allah continue to bless his soul in good health for the benefit of humanity. My teachers at the University of Maiduguri in medical microbiology laid the foundation. I shall specially mention and appreciate Professors Sambo Zailani and Gazama Galadima, who provided me with the key for initial entry into the microbial world as an undergraduate medical student. At postgraduate level, I will eternally appreciate Professor Bakari and Dr. Fotade, the late Professor Abimbola Oluoshoba, and all others at the University College Hospital, Ibadan. Professor Bakari has remained a patient and committed father and mentor who admitted and guided me through residency and continued to push and support me even as a professor. He is always there for me. Dr. Adeola Fotade co-supervised my fellowship dissertations and has continued to make significant impact and inputs even up to this moment, including this inaugural lecture. Late Professor Abimbola Oshoba gave me unhindered access to him and introduced me to the art of scientific writing and critical thinking in medical microbiology. May the Almighty continue to guide and bless his family. My colleagues from Gombe, with whom we spent time in Ibadan, were very supportive and understanding. Professor Musa Ali Gombe, Ali Ibrahim Lawan, Yusuf Abdullahi, the Chief Medical Director, Saleh Yuguda, Professor Sani Adamu, the CMAC, and Daladi Adambo today were there for me as a family. I wish to pay special tribute to all my friends under the Jewel Sanity Aid Foundation for the vision and togetherness we share. My colleagues and residents in the Department of Medical Microbiology, FTH and GSU, Dr. Ibrahim Mohammed, Dr. Umar Maigado, and Dr. Umar Mohammed Hassan are my most important seats in medical microbiology. To my medical students, your understanding and appreciation of medical microbiology and subsequent graduation as doctors is a major source of joy to me while practicing and working in Nigeria. My colleagues in medical microbiology department, medical laboratory scientists, and all other staff within the hospital and university are very wonderful. And I specifically at this point wish to appreciate Mr. Kudi Ayuba, Alaji Saminu Chiranchi, and Mr. Dallami for spearheading a harmonious working and productive relationship in our department. At this point again, I wish to specially recognize Dr. Ibrahim Jalo Daudu. He deserves a special mention. He has been my mentor and guardian who supported me through everything and has remained a father and referee at all stages. I must not forget and thank all my siblings, uncles, and aunties, too numerous to mention. My friend and lifetime confidant, Engineer M.K. Hassan PhD, is a hidden pillar in all my successes. He forces me onto the right path, even subconsciously. Dr. Yahya Mohammed is my microbial twin brother. with whom we synergistically navigated through the journey up till this moment. And I want to acknowledge his presence all the way from Abuja for this purpose. To the members of the University Ceremonies Committee, headed by our father, Professor Muhammed Manga, I sincerely appreciate your support and encouragement. Although it is impossible to remember and acknowledge everyone, may the all-knowing recognize, bless, and reward you all with the best of rewards here and hereafter. Finally, my deepest appreciation goes to the Gombe State University and Federal Teaching Hospital, Gombe, and their founding fathers, and all stakeholders for providing the platform for my battles in health and medical education with the microbes. I pray fervently for every leader that will continue to uplift the status and relevance of these institutions for the sake of humanity. Mr. Vice Chancellor, sir, I have benefited from love, support of human beings. I am a privileged nomadic microbial pathologist in Nigeria. Standing right here in this multipurpose hall in Gombe State University is a place between where my father was born in Malam Inna and where my grandmother was born in Jauri Abani, and where I was born together with my mom in Shamaki Ward here in Tudunwada, Gombe. I believe this is part of the privileges and divine coincidence. In the end, I remember a verse from the Holy Book Al-Quran, which says, "So which of the favors of your Lord will you deny?" And I say, Alhamdulillah, Rabbil Alameen, Ar-Rahman, Ar-Rahim. I seek for His mercies and blessings in the remaining days of my life. Thank you very much.
Thank you very much. Once again, we rise up and give a round of applause. Thank you very much, the lecturer, Professor Manga. You have done a good job in analyzing all that you have said. Thank you very much once again. We are running short of time. May I invite the Deputy Vice Chancellor, Professor Sani Ahmed Yautra. Can you come over to give us the closing remarks?
The Vice Chancellor of Gombe State University, Professor Ali Usman El-Nafati, OFR. We thank you most sincerely for giving us this opportunity, for giving the professors of Gombe State University the opportunity to come and profess their findings. We hope and pray that these privileges will be sustained by you, Mr. Vice Chancellor, sir. We thank you most sincerely. And it is on record that Gombe State University is one of the universities that presented inaugural lecture for up to 7 times within the span of only a year. And this is a very huge success for Gombe State University. And by this we want to demonstrate that Gombe State University is first among equal, as our motto says, primus inter pares. The visiting vice chancellors from Federal University, Kashere, Professor Umar Alajipate, the Kaigama of Adamawa. Prof, sir, you are welcome, and we thank you most sincerely for honoring our invitation. The Vice Chancellor of Northeastern University, Gombe, Professor Yahya Yusuf, sir, we are most grateful that you have our time to come. Our professor, the first emeritus professor of Gombe State University, Professor Idris Mohammed, Prof, sir, we are honored and privileged that you have come. Thank you very much for coming. The convocation lecturer, which I started calling him since last week as the Nomadic Microbial warrior, and I will continue to do that. We thank you for making this presentation. Professors from within the universities and outside the universities, we thank you most sincerely for honoring our invitation to come and witness this historic occasion. We want to thank most sincerely the biological father of our guest lecturer that have time to come and listen to his son as he processed to be inaugurated as a professor in the university. We also wish to thank the Honorable Commissioner of Health, Dr. Habu Dahiru, for finding time to visit us, come and listen to the convocation lecture. Mr. Commissioner, sir, you are welcome and we thank you most sincerely. And also our own, the Commissioner for Science and Technology, Dr. Bofa Gakwa, you are welcome. We appreciate you that you have come to this lecture. Finally, the chairman and members of the organizing committee, you have done well and you will continue to do well. We pray you continue to do well. Professor Edji Duku, we thank you most sincerely for organizing this wonderful event and successful event. We thank each and every one of us that come here. Numerous to mention. Our students, we thank you most sincerely for finding time to come. Distinguished ladies and gentlemen, I thank you all on behalf of Gombe State University, and at the end of it all, we wish each and every one of us here journey masses back to your respective destination. Thank you very much.
Thank you very much, sir. That's the Deputy Vice Chancellor Academics, Dr. Sani Ahmed Yauta. Thank you. Ladies and gentlemen, we have come to the end of this program. We are now going to take the national anthem, and then the procession will move out in reverse order. That is, those that came last, the Vice Chancellor and his team will move out first, led by the Kakaki, and then later on all of us will depart one after the other. Thank you very much. Can we take the national anthem,
Every time I see you,